Welcome back to A for Medicine. This is your host Rahul Srivastav. In this video, we are going to walk through the practical 10-minute blueprint for acne management in primary care based on the recent NICE guideline and the April 2026 update, with a focus on what to actually do in the clinic tomorrow morning. Acne affects around 80% of people between 11 and 30, and often involving the face, chest, and the back. But the impact goes well beyond the skin. Self esteem, social functioning, schoolwork, and mental health are all on the line. As GPs and primary care clinicians, our goals are simple but important: reduce lesion severity, prevent recurrence, avoid permanent scarring, minimize antibiotic resistance, and keep patients safe, especially those who can become pregnant. Before we jump into regimens, let's understand a bit of physiology as a refresher, which will help us understand how the treatment makes sense. Acne is an inflammatory disease of the pilosebaceous unit. That's the hair follicle plus its sebaceous gland. It is driven by four key processes. Number one, excess sebum production under androgen influence. Number two, abnormal follicular keratinization causing microcomedones. Overgrowth, third is overgrowth of Cutibacterium acnes. And the last one is an exaggerated inflammatory response. Sebum and sticky keratin pluck the follicle to form comedones. Cutibacterium acnes, or C. acnes for short, then thrives in this lipid rich, low oxygen environment, and the host immune response produces papules, pustules, and nodules. This is why our treatment works. Retinoids normalize keratinization and are comedolytic. Benzoyl peroxide kills Cutibacterium acnes without driving resistance, and antibiotic reduce Cutibacterium acnes activity and inflammation. Azelaic acid is anti-inflammatory and comedolytic, and isotretinoin targets almost the whole pathway by shrinking sebaceous glands and dramatically reducing sebum. In clinic, NICE asks us to classify severity using lesion counts, but think of it as a continuum and classify on the most severe feature present. Mild to moderate acne includes any number of comedones, up to 34 inflammatory lesions, and up to 2 nodules. Moderate to severe acne means 35 or more inflammatory lesions or 3 or more nodules, especially when this affects the face, the chest, or the back. In practice, I do a quick zonal scan. Is there nodular disease, extensive truncal involvement, active scarring, or significant pigmentary change? If yes, I treat more assertively and consider whether this is already moving beyond mild simple acne. Alongside physical severity, add a mental health severity overlay. Persistent distress, anxiety, depression, or body dysmorphic disorder can make clinically mild acne functionally severe. We'd like to introduce our books which are available on Amazon. And these are our very popular book on minor illnesses, which is available for £39, and a recently launched book on endocrinology and metabolic disorders, particularly useful for trainees who are approaching or preparing for the AKT exam. Please have a look. They're both available via Amazon, and you can order via Amazon Prime. Thank you. Acne of any severity can cause significant psychological distress, and this does not always track with the number of spots. For every patient, ask briefly about mood, self esteem, social avoidance, and thought of self harm. A simple question like, how much is this affecting your day to day life, can open the door. Red flags for urgent mental health referral include suicidal ideation, self harm, severe depression or anxiety, and suspected body dysmorphic disorder. Importantly, before referring for isotretinoin, assess suicide and self harm risk and document this clearly. NICE and MHRA guidance expect robust mental health assessment and monitoring around isotretinoin use. Let's move to simple high yield skincare advice. The small changes that make prescription work better and reduce callbacks. Recommend a pH neutral or slightly acidic synthetic detergent cleanser, a Syndet, once or twice daily. Avoid harsh scrubs because they disrupt the skin barrier and may worsen irritation. Advise non comedogenic, oil free moisturizers, sunscreen, and makeup. Non comedogenic simply means less likely to block the pores. This is especially important when starting retinoids or benzoyl peroxide because barrier support reduces irritation and improves adherence. Ask patients explicitly not to pick on or squeeze lesions. Picking increases inflammation, post inflammatory hyperpigmentation, and scarring. You can also mention that evidence for specific acne diets is limited. Encourage a balanced diet, but avoid over medicalizing single food. For mild to moderate acne, NICE recommends 12 weeks course of fixed combination or topical treatments. This is where most primary care prescribing lives. Option 1 is adapalene plus benzoyl peroxide, a retinoid plus a bactericidal agent in one preparation, which helps adherence. Adapalene is a topical retinoid. It binds retinoic acid receptors, normalizes follicular keratinization, reduces microcomedone formation, and has anti inflammatory effects. In simple terms, it helps unblock the follicle and prevents new lesions forming. Benzoyl peroxide releases reactive oxygen species on contact with skin, which are directly bactericidal to Cutibacterium acnes. Crucially, it does this without causing antimicrobial resistance, which is why it is so useful in combination regimens. Other nice listed options include tretinoin plus clindamycin or benzoyl peroxide plus clindamycin. But remember, these are combination products. We should not be using topical antibiotic monotherapy. A practical clinical tip, rather than a specific NICE instruction, is to start retinoid containing products, alternate night, or as short contact therapy. For example, applying for 1 hour, then washing off, and building up as tolerated with a light non comedogenic moisturizer. For moderate to severe acne, NICE recommends a 12-week combination of an oral tetracycline with a suitable topical treatment, again avoiding antibiotic monotherapy. The first pathway is oral limacycline or doxycycline plus adapalene and benzoyl peroxide. The second is oral limacycline or doxycycline plus azelaic acid. Tetracyclines such as limacycline and doxycycline inhibit bacterial protein synthesis at the 30S ribosomal subunit. In acne, they produce Cutibacterium acnes, they reduce Cutibacterium acne activity and also have anti-inflammatory effects. Azelaic acid is a dicarboxylic acid with the comedolytic, antibacterial, and anti-inflammatory properties. It may also help post-inflammatory hyperpigmentation, which is particularly relevant in darker skin types. Two antibiotic rules matter most. Never use topical or antibiotic monotherapy, and never combine topical and oral antibiotics together. Always pair antibiotics with a non antibiotic agent, such as benzoyl peroxide, retinoid, or azelaic acid. Whichever pathway you choose, build a clear 12-week review point at some point of prescribing, even if it is booked under telephone review. At At 12 weeks, assess response, adherence, tolerability, and side effects. If the skin is clear, stop the oral antibiotic and continue topical maintenance where appropriate. If there is good improvement but incomplete clearance, you can continue the oral antibiotic for a further of 12 weeks alongside the topical treatment. But keep total antibiotic duration under 6 months wherever possible. Antibiotic beyond 6 months should be exceptional, reviewed regularly, and stopped as soon as possible. If acne has not responded after 12 to completed 12-week primary care courses, that is your cue to consider referral. Next, safety in people who can become pregnant, a critical part of acne prescribing. Topical retinoids and oral tetracyclines are contraindicated during pregnancy and when planning pregnancy. So, before prescribing, check pregnancy status, pregnancy intention, and contraception. Document this clearly. If hormonal contraception is wanted, the combined oral contraceptive pill may be preferred for acne where appropriate. Some progesterone only pills, particularly those with higher androgenic activity, such as levonorgestrel, may worsen acne in some patients, while others may have less effect. Before isotretinoin, specialist services will implement the MHRA pregnancy prevention program, but primary care still has an important role in early counseling, contraception discussion, and safe referral. Oral isotretinoin, often known by the brand name Roaccutane, is a game changer in severe or refractory acne, but in the UK it is for a specialist initiation only. Usually, a consultant dermatologist or an accredited GP with extended role working with a consultant dermatologist agreed pathway. Mechanistically, isotretinoin is powerful because it targets almost every major step in acne physiology. It reduces sebaceous gland size, reduces sebum production, normalizes follicular keratinization, reduces Cutibacterium acne colonization, and has anti-inflammatory effects. Following a January 2026 MHRA regulatory update, NICE amended NG1, the guidance 198 in April 2026 to remove the two clinician approval requirement for isotretinoin in under 18s. But this does not mean relaxed safety. MHRA risk minimization measures remain mandatory, including pregnancy prevention where relevant, patient information materials, and monitoring for mental health and sexual function side effects. As GPs, our role is to optimize standard treatment first, identify candidates early, counsel about expectations and risks, and send high quality referrals with, with previous treatments, mental health history, and contraception status clearly documented. Knowing when to escalate is just as important as knowing what to prescribe. Routine dermatology referral is appropriate when there is diagnostic uncertainty, acne conglobata, nodulocystic acne, failure to respond to two completed 12-week primary care course, scarring or persistent pigmentary change. Acne conglobata means severe nodulocystic acne with interconnecting sinuses and abscesses. Nodulocystic acne means deep, painful nodules or cysts, usually with a high risk of scarring. Urgent referral is required for suspected acne fulminans and for acne of any severity causing severe mental health concern, significant mental health concern, especially when there is self harm or suicidal ideation. Acne fulminans sometimes is rare but important not to miss. NICE describes it as a very serious form of acne conglobata associated with systemic symptoms. Clinically, think abrupt onset of severe, painful, ulcerated nodular acne, often on the chest and back with systemic upset. It classically affects adolescent males and may present with bleeding crusted ulcers, fever, malaise, weight loss, and painful joints. Musculoskeletal involvement can include the sternum, clavicles, and sternoclavicular area. It can also be precipitated by oral isotretinoin, a key reason for urgent review in any patient on isotretinoin who develops a sudden painful flare. The physiology is thought to involve an explosive inflammatory or hypersensitivity reaction to Cutibacterium acnes, often in a background of androgen driven seborrhea and genetic susceptibility. In primary care, the key is recognition and rapid action. If you suspect acne fulminans, severe sudden pain, ulceration, and systemic symptoms, arrange same-day referral to the on-call hospital dermatology team for assessment within 24 hours. Dermlet describes acne fulminans as a rare, very severe form of acne conglobata with systemic symptoms, and StatPulse notes that high-dose acetretinoin can trigger it, and that skeletal involvement may include the clavicle and sternum. To close the clinical context, here are the five practical rules that will transform acne consultations. First, never use antibiotic monotherapy, topical or oral, and never combine topical and oral antibiotics. Always pair antibiotic with a non-antibiotic agent such as benzoyl peroxide, retinoid, or azelaic acid. Second, always plan a 12-week review. Stop antibiotics as soon as the skin clears and aim for a maximum of 6 months of total antibiotic use. Third, assess mental health impact at baseline and review. Acne of any severity can cause significant distress. Fourth, remember pregnancy safety. Avoid topical retinoids and oral tetracyclines during pregnancy and when planning pregnancy. Fifth, remember the January 2026 MHRA isotretinoin update reflected in NICE guidance number 198 in April 2026. The two clinician approval requirement for under 18s has been removed, but MHRA safety measures remain essential. Thank you for if you found thank you for seeing this presentation. If you found this acne blueprint helpful, subscribe to Evo Medicine and please like the video. And we'll be presenting many more concise evidence-based summaries of NICE guidance for everyday primary care. For a next step, consider watching our videos for on acne differentials, post-inflammatory hyperpigmentation and scarring, and acetretinoin counseling. You can find structured management guides, flowcharts, and exam-focused resources at a4medicine.co.uk, ideal for GP trainees, pharmacists, nurses, and allied clinicians in primary care. Thank you.